Hello everyone. Welcome to Doc Talks. Today we have Dr. Nicholas Klemen with us. I'm Dr. Manju George, the Scientific Director of Paltown Development Foundation, the nonprofit that supports Town. It's great to have everyone here. If you haven't watched the first session with Dr. Klemen about trials at the NIH, the video is posted on Town University in the lecture hall. Please make sure to watch it. So, Dr. Klemen, take it away.
All right. Well, thank you so much for having me back. It's really thank you for the opportunity to speak. I do apologize in advance. I'm still coughing and a little hoarse. I had some daycare-itis last week. I have 2 kids in 2 different daycares, so twice the fun. So please bear with me if I'm coughing every now and again. So yeah, looking forward to telling everybody a little bit about TIL therapy for metastatic colorectal cancer. I have no disclosures for myself, although our group does have a collaborative agreement with Iovance Biotherapeutics, which I'll talk a little bit about what they're doing. So just an outline of what we're going to discuss today. I'm going to first get in the very basics. I'm going to try to keep this sort of very straightforward and not get into a lot of like jargon and in-depth science. There's a lot of material out there available for those who are interested in that. But I'm going to talk a little bit about what TILs are, or tumor-infiltrating lymphocytes, talk about how we build a TIL therapy, what it looks like clinically to get it, and then I'll talk about how it all started in melanoma and then how we're trying to make it happen in colorectal cancer. And then the last thing I'll talk about are just some clinical challenges in doing this. So what are TILs? So the first part is the easiest. So TIL stands for tumor-infiltrating lymphocytes. And the tumor-infiltrating part just means that these are lymphocytes that are going into the tumor. So just in this simple cartoon, you can see the pink cells are sort of inside the tumor in various places. And it was first observed decades ago that there were these lymphocytes into tumors, and for a long time, people didn't really understand what they were doing or why were they there. This is, sorry for the images being a little bit grainy. These are just histopathologic slides. So if you have one of your tumors removed, a pathologist looks at it under a microscope. So this is sort of like a high-level view of what one of colorectal tumors might look like under a microscope. And the pathologist uses a special dye that can stain for a marker that's on TILs, and that dye appears to be brown in this. So here you can see the top 3 are just examples of 3 specimens where there are very few TILs, and on the bottom, these are examples of specimens where there are lots of TILs. So there's a lot of variation, and as I'll show you later, in colorectal cancer, I mean, it's well established that this is an important prognostic marker. Patients who have many TILs in their tumors when they're taken out initially do have better outcomes. Now, okay, so we talked about what the tumor infiltrating part of it is. That's the easy part. Well, what are lymphocytes? Well, lymphocytes are a special type of white blood cell. The main 3 lymphocytes that we think of are T cells, which can include CD8, sort of classically called cytotoxic lymphocytes, CD4 T cells, which are also called helpers. And there are lots of other types, but the CD8s and the CD4s are the main 2. And then there are other important ones that are regulatory lymphocytes. Could talk all day about those. There are also B cells, which of course make antibody. Those are B lymphocytes. And then there are natural killer cells. The important thing to know is that lymphocytes are the driver of the adaptive immune system. Okay, so what's the adaptive immune system? Well, you can really broadly think of your immune system as having 2 big separate components. There's the innate immune system, and there's the adaptive immune system. The innate immune system is kind of what you're born with. It doesn't require training. It's like automatic. So it's, a rapid response, but it's a very non-specific response, if that makes sense. And the strength of the response is fixed. So it's not like it gets better over time. It's always the same. And there's no memory with the innate immune system. So the innate immune system is more primitive. It's more primordial. the adaptive immune system, the response can be delayed initially, but it's highly specific to the specific thing that's causing the immune system to go active, right? So if it's like a virus or something, and then it's adaptive so that it can change over time, and there is a memory function in it. So that's a lot of text and description verbally, but I guess, you could think of an analogy, right? You think of your immune system as an analogy, think about your body and responding to threats, right? If you're walking around the woods and you hear and then turn around and see a giant bear charging at you, it doesn't matter if you speak, English or Spanish or whatever, or it doesn't matter if you've been to school or not, you're going to run away. Everybody knows that this bear is a threat. Now, you see some guy standing there with an axe, that also looks like something that is probably a threat. Although, it takes some sophistication because on October 31st, this is a lot less threatening. But then on the other end of the spectrum, maybe this guy here, right? This is a scam artist. So, a lot of people fall victims to scam artists because they cannot detect that very subtle threat that a scam artist presents. And so the immune system sort of works in the exact same way. The equivalent of the charging bear of an immune system for your immune system is bacteria in your blood. So if your body sees bacteria in the blood, say E. coli cells, the E. coli is so different than anything that should be in the human body that the immune system does not need any special tools to go after that. They just blast it away immediately. Now you can think of, the way a virus works, right? A virus, little virus particles go in. And so now this red cell is infected with virus particles. Now the cell is self, right? It's your cell. So how does your immune system figure out how to kill your cell? Well, it can figure that out because the virus DNA is foreign, right? So this CD8 T cell can taste little pieces of this protein that are presented on the surface of the HLA molecules and can say that's a completely foreign DNA fragment, so we're going to kill that cell. Now, cancer is really the most difficult thing for the immune system to get rid of because cancer cells really, they're your own cells, and the DNA is really almost normal. It's the genes are usually, they often will change by just like a single spot will change in the DNA. And so it's very hard for your immune system to detect a cancer cell. Now, sometimes cancer cells do things that can trigger the immune system, like if they look like they're sick or dying and things. But to actually specifically detect the cancer, it's challenging. And really, in truth, T cells are the only immune cells that can, quote unquote, see the specific mutations in cancer. Now, give you this example here. So a normal cell, right? You've got your DNA. The DNA becomes RNA. The RNA becomes protein. And then you make a finished protein product. And now what the body always is doing is taking little pieces of this protein and putting it in the MHC molecules. And that's where the T cell then can come and taste that protein if it's on the MHC and can say, hey, that's a normal protein. In the case of a cancer cell, you have the DNA, it's all the same, but there's one spot where there's a mutation. That one mutation then can go into RNA, and that, for example, a KRAS, right? A lot of people have KRAS mutations. That's a single change in the gene there. So now the RNA is a little bit different, and then this amino acid fragment is all the same except for one amino acid is different. Well, that becomes this finished protein, and now when those get presented, sometimes a T cell can sense those. T cells are really the only immune cells that are capable of detecting a mutation like this. No other cells can do that. And so that's why T cells are so powerful, and that's the main thing we're interested in TIL. So when we say TIL, what we are mainly interested in are the CD8 T cells and the CD4 T cells. Now, there's also natural killer cells in TIL, but it's sort of a separate discussion. And we are not convinced they do all that much. Okay, so how is TIL therapy built? Very simply, and I'm sorry this is a little bit grainy, but very simply the way that it works is that we remove a tumor from the patient's body. Doesn't have to be big. I'll talk a little bit more about that later. This is a cartoon of a cross section of the tumor. So here you can see the blue cells are tumor cells, These green cells maybe are myeloid cells or some other type of cell. And then the little red ones here, these are, let's say, TILs, they're maybe T cells. And we can put this in a dish and give a special media, special growth factors. And these little red cells will grow in numbers and start leaving the tumors in the dish, and they start killing the cancer cells, and they will eventually expand into large numbers. And once we get enough of these cells, we then reinfuse them back into the patient after lymphodepletion, which I'll talk about in a second. So that's very simply how it's done. So again, just to sort of verbalize it, it involves a tumor surgical excision of about a 1.5 centimeter tumor. That's all we need. The tumor is cut into pieces, put it in the dishes. The T cells then migrate out of the tumor, begin to multiply. Step 4 is, I'll talk a little bit more about later, but we have to identify which of the TILs can see the cancer. And then we can either expand the cells for immediate use, or we can freeze them actually. And you can cryopreserve them for a long time, and they're fine and they're happy. Okay, so what does TIL therapy look like clinically? So it's one treatment, right? So normally when you get chemotherapy, you go in for cycles, and it's every 2 weeks or every 3 weeks. Then you go on a break, and then you get the next cycle, and it's like over a period of 6 months or sometimes longer. That's the way chemotherapy, systemic therapies are normally done, or even like BRAF inhibitors. You can take a pill, you take it every, pill every day, every 2 weeks. It's a constant thing. TIL therapy is a one-time thing. It's one treatment because it's a living drug, right? When you take a pill, it's a drug that gets metabolized and eventually leaves your body, and it no longer does anything. When we give TIL, we're giving live T cells. Those cells have the ability to live in the body, to grow in the body, and expand in the body. So when we talk about TIL therapy, we're talking about one treatment. But that one treatment it's a big deal. So first, it involves lymphodepletion, which is 5 days of chemotherapy that we give before the cells, before the TIL. We also do pembrolizumab. We do 4 doses of that. The first dose is given the day before the TIL. We have you come back to the NIH. If we do it here, we have people come back every 3 weeks for 4 doses total. You get the TIL infusion on day 0, and it's kind of anticlimactic. It's a huge process, but it's just that you end up getting a IV bag basically, and it's full of white cells, and they go in your body, and that's it. Then we give an immune stimulant for a few days after the cells go in, and we give this stimulant called IL-2, and that interleukin-2, and that helps the TIL cells to grow and be happy in your body. And then the last part is just recovery, waiting for the body to the blood counts to normalize after the lymphodepletion, waiting for fevers and cytokines to come back to normal. And so it's a lot. So this therapy involves a lot of back and forth to the NIH, on our TIL protocol, a lot of back and forth. And it involves a single inpatient stay of about 2.5 weeks. So it's a serious commitment. So why is chemotherapy given before TILs? Well, I guess the simplest way to think about it would be, if you were going to move into this house, what would be the first thing you would do? And we would say, well, let's clean it out, right? You got to make space. So that's the most obvious reason why we give chemotherapy before TILs. It provides space for TILs. The chemotherapy gets rid of all of not all, but most of the existing immune cells in the body. And so that provides space for the T cells that we're giving. Now, a little bit more sophisticated explanation for that is that the chemotherapy promotes homeostatic expansion of the TILs. What does that mean? Your body is always trying to achieve homeostasis, which means it's like at a balance, right? So if you're too hot, your vessels dilate and you sweat because your body's now cooling you down. If you're too cold, your body shivers to make more heat, right? If you have too much fluid in your body, you make more urine. If you don't have enough fluid, your kidneys hold on to the urine. And so if you have too many T cells in your body, like if we just gave you TIL, billions and billions of T cells, but didn't do anything else, your body would say, hey, we got way too many immune cells. We don't need this many immune cells. We're going to let a whole bunch of them die. But on the other hand, if you give this chemotherapy first, now the body says, whoa, 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 we don't have any immune cells, right? We have a shortage of immune cells. We need to make more immune cells. We need to make them fast. So then your body is going to release all sorts of hormones that will be hormones that make T cells grow and be happy. And we infuse the TILs just as that is happening. And so we think that that helps them grow and be happy. And then it's also, this chemotherapy potentially helps deplete a lot of the immunosuppressive cells that are in your body and in the tumor, right? So the body has regulatory T cells, which can shut down the immune system. The tumor can have macrophages and other cells that suppress the T cells. Because you may be wondering, well, if the T cells were in the tumor in the first place, why weren't they working? Well, the answer was that they were there, but they were suppressed or they were outnumbered. And so depleting all of the immunosuppressive elements can help release the brakes. So the expected side effects of TIL therapy, a lot of it is due to this chemotherapy. So because we give you the chemotherapy, it suppresses the counts. That results typically in some anemia. So patients often require a few transfusions of red blood cells. Sometimes they require transfusion of platelets. The chemotherapy also knocks down the neutrophil count, and those are white blood cells that fight bacteria. And so that leaves you vulnerable to a bloodstream infection for about a week. And sometimes that happens a week of antibiotics and it's fine. And those counts come back. But during that time, that's part of the reason why it's an inpatient stay, is to watch patients when this is the case. Now, there are also immune side effects of the cells in the interleukin 2. So the cells, this can result in cytokine storm, which is something that happens with CAR T a lot, where you're releasing a lot of immune hormones in the body. And so essentially it's like having, the worst flu of your life for a few days. But it's transient and it gets better after a while. And so this whole process also, results in some fatigue and some loss of appetite. So it's quite a slog, those 2.5 weeks in the hospital, sometimes longer. Now, and there are also, unfortunately, unexpected side effects of TIL therapy. And so, one of the things that can happen is organ failure, resulting from an overstimulated immune system. So what we're trying to accomplish here is we're trying to rev up the immune system to fight the cancer. But if the immune system gets overstimulated, it can be dangerous. And the two common problems we see is, breathing. If there's so much inflammation in the lungs, that can be a problem, and it can require intubation in the worst case scenario. And it usually, gets better. All these toxicities get better with time, but it can be problematic in the short term. And the kidneys also can take a hit from all this. And in the worst cases, it can require dialysis for a month, although that's pretty rare. Also, there are some patients, an unexpected side effect is a very delayed recovery of blood counts. So some patients who've had really extensive prior chemotherapy, when we give the lymphodepleting chemotherapy for the protocol, they don't recover as fast as we would expect. Now, we're getting good at learning how to dose reduce the chemo so that if we think, hey, this patient's had a lot of chemo before, we should maybe give less so that they recover better. We've gotten pretty good at doing that, but it's still a potential risk that can happen. And then finally, there's a risk of autoimmune side effects because we do give pembrolizumab as a part of our protocol. Pembrolizumab has autoimmune side effects, and now TIL alone almost never causes autoimmunity. But the combination of them, it's theoretically there could be even a higher risk of autoimmune side effects, so that's not totally clear. So I've sort of talked to you about what TIL looks like clinically, and you're probably all thinking, that doesn't sound so great. So let's talk about the data and why we're excited about this treatment and why we think that this is worth pursuing scientifically and clinically. And you can't tell the story of TIL without starting with melanoma, because that's where this all started. So up until recently, the median survival of metastatic melanoma was 6 to 12 months, and there were really no good effective long-term effective therapies. And you can hear in the long-term survival, there are very few patients that made it out to 5 years. Now, TIL therapy was first pioneered and described here in the surgery branch by my boss, who's still my boss, Steve Rosenberg. And this is from this seminal paper back in 1988 in the New England Journal. Here you can see this patient with metastatic melanoma. Back then, they didn't even do the CAT scans, but you can see these two big lung metastases this patient had. And here you can see 2 years later, those lung metastases are completely gone. Here's a patient with melanoma who had a whole bunch of metastatic tumors in the liver. And here's 30 days after TIL treatment. And you can see they've mostly resolved. And this patient went on to have a complete response and was cancer-free for years after this. And so this figure is really what, for me, is why this job was so appealing to me and why I wanted to, dedicate my research efforts to TIL therapy and to cell therapy. A single infusion of TIL in melanoma in about 25% of patients will cause a complete response. And what's amazing about these complete responses is that they're almost always durable, meaning if you get a complete response, the cancer usually never comes back. So this figure here in the gray bar on the top, these are the complete responders. So we call them a complete responder at some point. And then if you follow these patients, here you can see 5 years, and then it jumps to like 9 years or something. But you can see all these little lines here. These little lines mean the patients were censored. So that means, they were 7 years after their treatment. So we can't say they're alive 10 years after their treatment, but we can say they're alive 7 years after their treatment. So you can see all these patients got TIL and had a complete response. And now over 5 years later, their cancer has never come back. And so that's really an amazing result in solid tumors, because you don't normally see that. You almost never see that with chemotherapy, right? Chemotherapy really never does that. And even some of the patients who had partial responses, here you can see here, and some of the patients that even didn't have an objective response by RECIST, some of these patients actually had pretty good responses, and maybe they had shrinkage in a lot of tumors, and maybe one tumor grew, and we took that tumor out surgically, and that was the last thing they had, and nothing ever came back. So these are the results that really excite us, and melanoma. And then there was also very recently, there was a randomized controlled trial where they took patients with melanoma who were refractory to immune checkpoint blockade, meaning they had all gotten PD-1, and then they said, okay, well, that didn't work. Let's try something else. So then they randomized the patients to TIL or to ipilimumab. And again, you can see TIL was way better. And you can see that, about 25% of the patients, the cancer, they never progressed. The cancer was under control for years. So that's the story in melanoma. And so now I think finally TIL is being commercialized. Again, I don't get any money from Iovance, so financial interest in me. I'm not like advertising for them here, but they're the company that's hopefully going to be FDA approved this year, or soon, I guess, to do this for melanoma. And so the way it'll work is that the tumors potentially get resected at any hospital, right? So you go to your local hospital, you get a tumor resected. That tumor gets shipped to the Iovance facility. They then grow the TIL and get them all ready for you. And then they put them in a bag and freeze it. And they ship that bag of TIL back to your hospital. And then your doctor at the hospital will do what we do here. And they give the chemo, they give the IL-2, and they give the cells. And so, I think this really changes things, right? Because for melanoma, patients sometimes get metastasectomies for stage 4 melanoma in the attempt to cure the disease. And in the past, those specimens were just discarded. But in the future, you especially see now this is an option. You don't necessarily want to throw those away. Those are potentially an invaluable patient resource. Of course, they're not discarded. They're studied by pathology and whatever, but they're not preserved. And so with TIL therapy as an option, those specimens are invaluable. All right, so now I've given all this background, and so let's talk about, well, how are we going to do TIL therapy for colorectal cancer? So the main difference one of the main differences between colorectal cancer and melanoma is the number of mutations. So this is a figure that's sort of commonly shown, but this shows on the x-axis on the bottom, this shows the median number of mutations in the cancer. And then on the y-axis, you're seeing this is the response rate to PD-1 blockade. And so you can see that metastatic melanoma is way up here. There's a lot of mutations, and they respond very well to PD-1 blockade, and they also respond well to TIL. And as I'm sure a lot of you know, colorectal cancers that are MMR deficient, which in the metastatic setting is only about 4%, but those 4%, they have a lot of mutations. And those patients do respond beautifully to PD-1 blockade. But if you look at the vast majority of colorectal cancers, 96% of them, the MMR proficient ones, they have a much lower burden of mutations, and they essentially never respond to PD-1 blockade. So that's the main difference between melanoma and colorectal cancer, at least in terms of the immune system. But what's interesting is that we've known for over 20 years that TILs are prognostic in MMR proficient colon cancer. So this is work first described by a European guy named Jerome Gallon, and he published in Science back in 2006. And he basically showed that if you look at a colorectal tumor, like a primary tumor, and you look at the infiltration of CD3 positive TILs in the center of the tumor and an invasive margin, the patients who have more TILs did a lot better. And in fact, he shows that looking at TILs gives you better prognostic information than the TNM staging, right? So if you get TNM staging right, you're like, if you have no lymph nodes, you're stage 2. If you have lymph nodes, you're stage 3. And then there's like different subcategories. They generated this thing called the immunoscore, which it's actually better prognostic than the TNM staging. So they would show, for example, that if you're stage 2 with a bad immunoscore, you're going to do worse than a stage 3 with a good immunoscore. Now, this is used in Europe. We don't use it much here, but the bottom line is this is MMR proficient colon cancer. So we've known for a long time that even though they don't respond to PD-1, they don't have a lot of mutations, that the immune system is clearly at least prognostic. And now one of the other interesting things is that when we looked in the surgery branch at the TILs taken from patients with these low mutational burden, MMR proficient colon cancers, the run-of-the-mill, not the rare MMR deficient ones. If you grow the TILs and you look, we show in almost 90% of the patients, you could find at least one type of T cell that was recognizing a mutation. In 90% of patients, they were there. And so this sort of led us to sort of an obvious way to change our treatment. So when we were doing melanoma, which we don't do much anymore, but when we were doing TIL for melanoma, imagine this, this is a simplification, but I think the concept is accurate. Here in red, imagine this bar graph. So if we grow from one patient, all the TILs, right? The TILs are all different. A lot of them recognize different things in the cancer, or they don't recognize the cancer at all. So there's a whole bunch of different types of T cells. And so some of those T cells are going to recognize the cancer and some don't. And so you could imagine in melanoma that maybe the red ones are the ones that recognize the cancer and maybe the blue ones don't. And so, most of these are recognizing the cancer. And so what we do in melanoma is we just sort of take them all, kind of kitchen sink approach, just take all these, grow them up, and then give them to the patient. It works great. Well, that works if you've got tons of mutations. But if you don't have tons of mutations, as in the case of colorectal cancer, what you'll find is that if you look at all of the TILs, well, we can almost always find at least one clone that does recognize the cancer. The vast majority do not. And so maybe a better strategy is to take these red ones, which are the tumor reactive clones, and grow those selectively. And now we end up with a cell product that is selected for the ones that recognize the cancer, grow those and give those to the patient. And so the first time we tried this was with a patient with metastatic cholangiocarcinoma. She has lung and liver metastases. And here you can see So this is flow cytometry data. I'm not going to show a lot of science, but I figured I'd show this. Each dot represents a single cell. So these are her TILs. And so what this shows you, this is a gene that she has in her body. We all have this gene. It's called ERBB2IP. And I don't actually remember exactly what it does. It doesn't really matter. But basically, these are her normal TILs. So here you can see they have this V beta 22, which is the type of receptor they have. And this is TNF, which is tumor necrosis factor. Necrosis is a fancy way of saying kind of an ugly cell death. So this is saying TNF is a protein that helps make tumor cells die an ugly death. So that's a good protein to have. So here you can see nothing happens. If you take the mutated version of this gene that she had in her cancer, and you expose her T cells to this mutated gene, you now see all of the T cells turn on and they start releasing TNF. And so we gave this patient her TIL treatment that was selected to be almost entirely these cells. And here you can see one of the liver tumors in 2013, and here 10 years later, they're all gone and they haven't come back. So that was the sort of one of our early attempts doing this. And so now this is one of our big approaches for colorectal cancer. Is so just a simplified diagram is we remove a tumor from a patient with colorectal cancer, and we plate the tumor in different spots so that you can see here we've got different types of T cells. And now we grow these cells in the lab. And so here you can see there's, two of the wells grew out green cells and two grew out yellow cells and two grew out blue cells. And then what we do is we check to see which of those recognize the cancer. And if it turns out that maybe only the blue cells recognize the cancer, then we select for those and we treat the patient with those, and the rest we just throw away. And so this is just an example of one patient with colorectal cancer. This patient had, here, 2 liver tumors. Here's another cut with two other liver tumors. And here's some shots of some lung tumors. And now this is, again, 8 months after a single infusion of TILs. Here you can see there's a little speck here, but this liver tumor is gone. Here you can see this big liver tumor is shrinking a lot. This little one's almost gone, and the lung tumors are mostly gone too. We don't know, what'll happen because it's still early, but this is a nice response. And so we have seen in colorectal cancer, we have a few patients who are years after a single treatment. So we do know that it's possible for this to work as well as it does in melanoma, but we just haven't figured out how to make it work that well reproducibly yet. So that's our main focus. And so how likely is TIL to work for a patient with metastatic colorectal cancer? Well, the first point I would want to say is that if we knew this would work, it wouldn't be experimental. It would just be the treatment that you get. But we've spent the better part of 10 years studying this. I will say the vast majority, especially of our early attempts, were unsuccessful. Now, there are a lot of reasons for that that I could sort of talk about all day. But the bottom line is most of them were unsuccessful. But we did have a few home runs in the sense of patients who've had one treatment that has lasted years. And it's those patients that really have shown us that this can work. And that's what really drives us to keep pushing this forward. So we're constantly trying to find new and better ways to grow the TILs and to select them. And we've made a lot of progress on that front. And so over the entire experience, we actually haven't even published our experience on this yet. So a lot of this is unpublished data. And so a lot of people don't know about it. And I would say over the entire experience, our average response rate is probably around 15 to 20%. I would say early on it was lower than that. And I can tell you sort of anecdotally, more recently, it's been a lot higher than that. But hard to know whether that success is because we're getting lucky or because our methods are actually better. It's too early to say. The final thing I wanted to talk about, and then I'm planning to leave, 20 minutes for discussion and questions if you have about it, have some, but I want to talk about the clinical challenges for this because there are many. The reality is, we are very selective here about enrolling patients on these TIL protocols. And it's not because we want to be, but it's because we have to be. So it's a really complicated process. So, so we've got first the initial workup. So we've got to know, first of all, when I first see a patient, we got to know how soon does this patient need treatment? Because it takes us months to put this together. So if the patient needs a treatment, in a month or in 2 weeks, it's not feasible. We also have to know if they're eligible for this study. I mean, we have eligibility criteria. Age has to be younger than 72, and there's some other ones that I'll detail a little bit. So then, if we say, okay, well, the patient may be reasonable to proceed, then we got to know, is the surgery safe? Because the first thing we have to do is resect a tumor. And can we stop the chemotherapy? Because we have to stop the chemotherapy at least a month before the surgery. Now, this is a big sticking point, because if all the tumors are in inconvenient locations, we don't think we're not going to put a patient through a major operation to get a tumor for TIL. And so this is a big issue that can come up. Then we've got to know, well, look, it's going to take us 3 months to do this, right? So it doesn't do anybody any favors if we take a tumor out and try to grow TILs, but if the patient doesn't have anything that they can do in the meantime, and the cancer is growing, then they're not going to be eligible once we get the TILs ready. So again, this is another reason why we're trying to predict all these things when we first see patients, is say, are we going to be able to do an operation? Okay, what are the patient going to do to bridge while we're getting this ready? Then let's say we finally get the cells to grow. They don't grow in everybody, but they grow in most people. And we say, okay, now can we stop the chemotherapy? Is the patient still eligible? Because sometimes patients have progressed and they're not eligible. We've got to make sure they're going to tolerate the treatment. And so that's even before they come in for the inpatient admission. So you can see that there's a lot of considerations. And so when we do this initial workup, we do turn a lot of people away, and we don't want to, but it's just a reality that if we do not think we can get a patient to the end goal, and the end goal being cells get in the body and the patient makes it out of the hospital safe, then we won't start down this road. So what are some of the key considerations for a tumor harvest? As I mentioned, the patient needs to be off systemic treatment for at least a month. The longer, the better, honestly. The tumor has to be at least 1.5 centimeters. Bigger is not necessarily better, so a small tumor works just fine. Now, unfortunately, we can't use the primary tumors themselves because they potentially are contaminated. So during the TIL culture, the bacteria from the primary tumor would contaminate them. The tumor can't have previously been irradiated, can't have like Y90, things like that. And then again, the key is that the TIL, if the purpose of the surgery is to take a tumor out for TIL, we only do it if it's minimal morbidity. So there are a lot of patients that need to get back on chemo ASAP, and we don't want to put somebody through something that requires, 4 or 6 weeks recovery or longer, because we know these people, people often need to get back on their chemo. So we like doing minimally invasive lung surgeries. I do minimally invasive liver surgeries. We'll do peritoneal tumors, something that patients recover quickly from. And again, it's important also because not only the patients need to get on chemo, but sometimes the TILs don't grow. And so if you've gone through surgery, major surgery, and then the TILs don't grow, that's not great. Now, there is a reason why I'm particularly excited, though, about TIL therapy as an option for patients with colorectal cancer. And that's because in colorectal cancer, as you know, metastasectomy is now a pretty routine part of clinical practice. So, you can think about how complicated this is for most of our patients. But if we do a metastasectomy and grow TIL from that makes it much easier, right? Because all this is out the window. If the metastasectomy is clinically indicated, then if we can grow TILs from that, fantastic. And if we can't, then no harm, no foul. And we can also cryopreserve the cells. And so if we can get TILs this way, then the question is just, is the patient eligible? Do they want this? When do they want it? And are they going to tolerate it? If the answer is yes, we get started. And so we have a few patients who, we took out their last tumor and they're, NED, but if they recur, this will be an option for them if they choose it. And so what are some of the key moments to consider joining a TIL study? I would say one of them, as I just mentioned, is again metastaectomy. In other words, that's a elective surgery, non-emergent elective surgery to remove a metastatic tumor, commonly liver, also lung or lymph node, whatever. Another key moment to consider is if a patient has been off chemo for a long time and now they have a new recurrence. If that's sometimes a good opportunity to join a TIL study, you would want to talk to your oncologist and make sure they would be comfortable delaying resuming chemo for 1 to 2 months. And then also patients who are planning to stop systemic therapy and let's say go on a chemo holiday, that's also a good time to consider joining a TIL study. And then what are some of the common barriers to joining a TIL study? So if tumors are causing major problems like a bowel obstruction, significant infectious risk is a big no-no for us because again, we're getting rid of your immune system, so you're vulnerable to infection. So if you already have an infectious risk, that's a big problem. So if you have infected fluid in the abdomen or liver infections can be a big problem. If there are problems with the immune system, like let's say HIV infection, or if patients are on immune suppressive medications like high-dose steroids, that's a problem. Patients who have more than 3 brain metastases, and then 5 and 6, declining performance status like losing weight, appetite, fatigue, intractable pain, or significant disease progressing. Those are just signs that it's unlikely that we're going to be able to get that a patient experiencing those symptoms, get them to the finish line. And we don't want to put anybody through unnecessary agony and waste time for something that they ultimately aren't going to get to try. The final comment I just wanted to very briefly make in the is to zoom out 30,000-foot view again. 2 big areas of immunotherapy are cellular therapy, which I've been talking about today, and checkpoint blockade. Cellular therapy, you can think of TIL, TCRT, and CAR-T. So TIL, we talked about today, came first, 1988. TCRT therapy actually came second. This is back in 2006, and that was done here as well. And then CAR-T has been around since 2011. The reason I mention that is because everybody's sort of heard of CAR-T, but even oncologists are like, oh, you guys have CAR-T for this? It's like, well, it's kind of like CAR-T, but 20 years younger. But the key difference, so I just wanted to highlight that we do have this option of TCRT, which is basically, it's just like TIL, but we get the receptor from TILs that recognize shared mutations, and we can engineer blood cells without the need of a surgery to recognize those mutations. And so, the pros and cons of TIL is that we have the most experience with TIL, but the con is that it requires surgery and they don't always grow. Well, the pro of TCRT therapy is that there's no surgery required, so we can potentially get to treatment much faster. But there are 2 big cons. One is that the patient needs to have the target and an HLA match. And the other problem is that all of our eggs in one basket, which is more of a theoretical problem. But we're targeting one mutation. And so if that cancer cell loses that mutation, then the treatment may fail. And to contrast, these CAR-T cells basically use a completely synthetic receptor, and they can only target cell surface proteins. So CAR-T cannot target mutations in cancer. And so that's a big problem for solid tumors. And so that's why I know there's some excitement for CAR-T in solid tumors, but we're less optimistic. But we do think TCRT is promising. And so every time we do a TIL harvest, we potentially can find receptors that can be used to treat other patients. So these are a library of a bunch of receptors that we have now. So we can target KRAS G12D, KRAS G12R, KRAS G12V, TP53 mutations. And we find all these receptors from individual patients. So this receptor here came from a patient with colorectal cancer. And this patient got TIL and is 5 years out of their treatment. But we are using the receptor taken from those TIL and using that to treat other patients. So that's a really cool way that this therapy can go forward, and how each patient that we treat potentially can be additive to help us treat others. So that's the end of my talk. As I said the last time, feel free to reach out. Our referral office email is here. And you can always email me directly. I'm happy to respond to emails if you are interested or have questions.
Hey, thank you very much, Dr. Klemen, especially since you're sick and you still made the time to talk to us. Thank you very much. So I have a couple of general questions, and then we can look at the questions in chat. So can you talk a little bit about MHC and HLA? I think people are a little bit confused, and what things to keep in mind, and how is all that related to TILs or TCRT?
Yeah, I sort of glossed over it, but the idea is that we're really trying to differentiate what is the normal to how does the immune system figure out what is a normal cell and what is an abnormal cell. And the way, in the case of T cells that recognize cancer, the way that it can do that is by sensing the individual mutations that are caused, that are driving the cancer. So it's these mutations, the problem is that they're not necessarily on the surface of the cell, right? That's the way cars work, is they recognize things on the surface of the cell. So it's something obvious that shouldn't be there potentially, and you can target it with an antibody. These are mutations that are hidden inside the cell. So the way the immune system works is it's constantly kind of reaching inside of itself, right? Every cell in your body is constantly, it's like taking a hand and reaches inside and pulls like little pieces of itself out and holds it up in the air and says, hey, T cell, come smell this. Make sure it smells okay. And the T cell comes and checks it. And if it smells bad, T cell will kill that cell, right? That your body is constantly doing that. Every cell does that. And so the hand is MHC. And every cell in your body has MHC, and they're constantly presenting little pieces of peptide. And that's how your body detects viruses, right? Because you get infected with a virus. So that MHC reaches in, randomly grabs a piece of protein. Maybe that was a piece of viral protein, right? Holds it out. And now the T cell says, hey, there's a viral protein there. Because otherwise, how would the T cell know what's inside the cell? So that's how MHC works. And that's why T cells are so powerful, is because they can detect those subtle mutations, whereas no other immune cell really can detect those.
Okay, thank you very much. So we can look at the questions here. So the first question is, if you have multiple mutations and TILs are selected against, for example, a KRAS mutation, are other populations of cancerous cells affected, or do you need a cocktail of TILs?
So other population. So when we try to do some diversity. So when we check for mutations, we often have multiple different pieces of the tumor, and we'll say, oh, these T cells are recognizing this mutation, and these T cells are recognizing this mutation, and these ones are recognizing a third mutation. We'll often kind of put them all together. We do think that diversity may be good, and so we'll go with that. And then the other thing we've been doing more recently, which if some of you have follow some of the science in the field, but you can generate organoids from patient tumor products. And an organoid is basically it's like a tumor that we grow in a dish. And we've more recently, it sort of sounds obvious to check the T cells against your tumor, right? I mean, that's like the most obvious thing to do, is like, well, why not just take a piece of the tumor and see if the T cells recognize that? It's really obvious. The reason why we couldn't always do it before is because you couldn't get the cells to grow that well, which is sort of a bad reason, right? It's like a technical problem. But now we have these organoid platforms. And so from every patient, we're trying to grow organoids, and we check the T cells against that. And we don't even necessarily know what the T cells are recognizing, but we're finding that the T cells that recognize those organoid in particular may be very, very good T cells. So we think that's a really good way to select them. Anyway, the long story short is I think it does give us a good cocktail of TILs, and we do try to achieve that.
Okay. So as against collecting TILs from a patient's tumor, or like having the engineered TILs, or off-the-shelf products, you probably have more diversity if you're collecting TILs from the patient. Is that true?
Yeah, you would. Yeah, we there's more diversity in a TIL product than a TCR product.
Okay. The next question is, how severe is the immune depletion in terms of immunosuppression, both immediately and long-term?
So, I mean, in the immediate term, in the week after the chemotherapy, the neutrophil count is essentially zero. So that's why we keep patients as an inpatient. Now, there is a risk of a bacterial infection, but it's generally, if we do surveillance blood cultures, and if we spot one, we treat them with antibiotics and it squashes it. And the blood counts come back, 7 to 10 days after the chemotherapy is done. And then long term, there really aren't. I mean, we do take patients, have them take a prophylactic medication for like 6 months when we wait for the CD4 T cells to come back, because they can be kind of slow. But clinically, the patients, I would say, it doesn't really affect them. Now, the caveat there is we have had patients we've treated who've had probably too much prior chemotherapy, or their cancer has really progressed to the point that it was really causing a lot of problems. And in some patients like that, sometimes their recovery can be a lot different and not well. But if patients are kind of in good shape coming in long term, they fully recover and feel fine. I mean, we just, so yeah, I would say long term, not really an issue.
Okay. So this is almost like a bone marrow transplantation, the lymphodepletion that happens before that, is it?
It's like a mini bone marrow. It's like a mini bone marrow transplant. We don't have to give like stem cells or anything, but it's the same idea. It's
okay. The next question is this likely to be effective for treatment-resistant MSI-high KRAS G12D mutated CRC?
Yeah, that's a good question. I mean, I think probably I would have to imagine that it would be more likely to work than the run-of-the-mill patient. The reason we don't know is because we just haven't gotten those patients. We haven't gotten referral. I don't think we've ever had a referral from somebody who had a checkpoint refractory MMR deficient tumor, but I think it would be more likely to work probably.
Okay. The next question was, can you please explain the clinical difference between TIL and TCR? I think your slides are really very nicely explained it. Grace, if you want more, please let us know. The next question is, TILs do not live forever. So does the body learn to make more tumor-specific cells, or does it kill the cancer quickly so it does not recur?
I'm not sure they don't live forever, actually. Most of them don't survive long, for months. I mean, any immune response, right? There's like there's like a big curve, right? So you get like a bunch of cells and then they taper off, but there's always a tail. I actually do think the TILs probably live for years, and they probably control the cancer for years. Yeah.
Okay.
But the body also could potentially make more cells. That's also possible.
Okay. So the next question is, who would be a patient that should be considered for TIL therapy? I think you kind of answered that in your talk too.
Yeah, it's one of the unfortunate things is, I mean, as I mentioned in my last talk, I mean, oncologists, and it's not a knock against oncologists. I mean, most people just don't know what's happening from a research standpoint. It's not their job to know, but also, like I said, we haven't even published our experience, and I don't know what other researchers doing. So it's not like, I mean, I guess if I wasn't a doctor, I would sort of assume that all doctors know like really exciting trials and would be getting their patients on them. It's just not the case. And so, the time to think about this is honestly kind of early. I mean, when you have, if there's metastatic disease in play, the problem is when patients are early in the metastatic treatment course where there isn't a lot of disease and they have good options, the oncologists don't always have a sense of urgency, right? They may say, well, maybe we can treat this with surgery, or, there's not, the cancer's not growing that much and we're going to control this for a while. And it's not until all the chemo options are exhausted and the cancer has really gotten out of control that sometimes then we get those referrals. And at that point, it's very difficult for us. It's more difficult than maybe it would have been. So I would just say, when should a patient be considered is, I highlighted those 3 points of like when to think about jumping on a TIL trial. The earlier the better, and especially if there's an opportunity to get a tumor grown for TIL early on. You don't have to use it, right? It's not a contract. I mean, if we grow TIL from a patient and they don't want to come here again, then that's their right, and we're happy with that. So
Okay. The next question is, have you had any success with BRAF mutated CRC?
yeah.
Okay.
Yep. Yeah, we pretty much only exclusively treat MMR proficient colorectal cancer, and a lot of our patients have BRAF mutations and KRAS mutations.
Okay. So the person who asked about the MSI high immune checkpoint inhibitor refractory, that patient is saying that she wants to chat. So maybe you got a patient. So this is a question from another patient. She says, so I'm currently NED, negative Signatera, and not doing chemo. If my Signatera turns positive and eventually a MET appears on scans, is it best not to do anything and just let it grow to 1.5 centimeters so it can be harvested for a TIL trial?
Yeah, I mean, that's a tough question, and it's something you'd have to talk with your oncologist about. I can imagine two scenarios. I mean, if there's literally only one tumor and it's growing, then it certainly would be very reasonable, I think, to watch one tumor and then say, okay, good. It's like 1.5, let's take it out, or maybe just a couple tumors. But I would say if there's like a whole bunch of tumors growing and your oncologist is getting nervous, and the oncologist, it's just a discussion. It would all depend on what systemic options do you have left, what's the molecular profile of the tumor. Does the oncologist feel like, yeah, we can wait versus no? So, short answer, I don't, maybe, I guess.
Okay. What's the next question? Yeah, what's happening in research to improve the response rates in CRC for the TILs, and is prior exposure to immunotherapy an exclusion?
Yeah, so the second question is no, it's not an exclusion. Unless patients have had a really bad, like sometimes checkpoint inhibitors can cause like permanent adrenal dysfunction. So patients are then on steroids for the rest of their life. If there was something like that, we may not be able to treat patients, but otherwise it's not an exclusion. And then in research, yeah, to improve the response rates, it's all about patient selection, right? I mean, think about this. If I said to you, okay, we're going to take PD-1 inhibitors and do a randomized trial of just all comers with metastatic colorectal cancer, the response rate would be like 1%, right? And if you did a survival curve, they would be basically over superimposing. And then you would incorrectly conclude that PD-1 blockade is not useful for colorectal cancer. But if you can identify patients, as we all know, that MMR deficient, even though they're only 4%, it's a game changer for those people. And so is this one of the same lessons here, is that, we are getting better at selecting the TILs, taking the T cells that are healthier, determining their reactivity, figuring out better ways to grow them. But then the other thing, in the future, is if we can figure out a better way to select the patients who are likely to benefit from this, then it would become much more powerful. We can say, look, it's not an option for everybody, but let's say it's an option for 30%. And if in that 30% we can get the response rates up to 60, 70%, that would be a really powerful thing versus kind of a blunt tool that's maybe not that useful for everybody.
Part of that question is also, if a patient progresses during bridging, like, they have the tumor removed, they're getting chemo, and then they're progressing. If the TILs are ready, can they move forward with the TIL trial?
Yeah, I mean, it's not necessarily about progression that's the problem, right? It's just if the progression makes us nervous about doing the treatment, or the progression does something that makes the patient ineligible. So we have, like all clinical trials, there's lots of rules about lab values have to be a certain amount, right? Kidney function has to be good, and there can't be these infectious risks. So if all those are still fine, even if it's progressing, that's not a problem. But if those things are changing or the patient's not doing well, then it makes us nervous.
Okay, okay. So from what you're saying, it looks like if there are if lots of patients when they have a metastatic lesion that can be removed, if they come to the NIH and have it removed there, then your chances of finding more TILs that are, that either you can grow and preserve or, use it for other people or the same patient, that will significantly increase, right?
We I'm sorry, say it one more time.
Meaning like if you get like a large number of tissues, like metastatic tissues that you can collect and then isolate those TILs, and then you can have a library of TILs that are, capable of being used in other people or for the same patient, then, how applicable all of this is for a larger number of patients would greatly increase,
Well,
right?
so we won't use the TILs for other patients, but we do use the receptors.
TCRs,
And
yeah.
and the TCRs can come from actually, so we a lot of them we get, like, you can get them from a patient with breast cancer and use it in a patient with colon cancer. One got from a patient with colon cancer, we use it in pancreas. It doesn't actually matter what tumor type it is, it's the mutation that's shared. But yeah, the more patients we do this with, the more receptors we find, and we're building this bank of receptors. So, and if people have a receptor, a match for one of our receptors, and other people are doing this too, but then you don't even need surgery. We can set up the treatment more quickly.
Okay, we'll go to the last question. So the patient asked, if you have stable disease in lungs with multiple lung mets, but are becoming intolerant to current standard of care chemo, would TIL be an option, or do you have to have some disease progression?
Yeah, I mean, it would be an option. Yeah. I mean, there are rules about enrolling people on trials. They have to have, there's some subtleties. I mean, the disease can't be shrinking, right? We wouldn't, if we went to enroll you the day, I mean, we would do a tumor harvest and everything, but if we brought a patient in for treatment and like all their cancer was shrinking, we would say, look, come back in 6 weeks and let's scan you again, because if we do this treatment and the cancer shrinking, nobody's going to know whether it was the treatment or whether it was what you had before. But otherwise, yeah, that's not an issue.
Okay, so you don't have to wait till, you have stable disease, that's fine, and you have lesions that you can harvest, that's still okay. You don't have to wait for things to grow more to be eligible for TIL trials.
Yeah, correct.
Okay, okay, okay.
But again, there is that month-long washout, so it's
okay. So they should be able, when they are off chemo, waiting for surgery, everything should not grow too much.
Well, again, yeah. I mean, it's really not about the growth; it's just about the consequences. If the growth causes,
them to be ineligible.
some issue, yeah.
Okay. Okay. Thank you so much. We are 3 minutes past the hour, and thank you very much. This was very informative.
Great. Thank you. Thank you for having me. Yeah. So I'm always available. Feel free to reach out.
Okay. Thank you. And
All
a
right.
video recording of this will be posted on Town University.
Okay. Excellent.
So, take care and hope you
have a nice
recover from
weekend.
your
Yeah.
infection soon.
Thank you. Yeah.
Okay.
Bye-bye.
Take care. Bye.